yet, so we'll just start and we'll figure it out. Sounds good. Great pleasure to be here today to represent the Focal Therapy Society. I'm the vice president of the society and one of the founding members. And Ingrid put a lot of effort into getting us down here. We really appreciate it. And she told me that Professor Aaron wanted to hear our talk. I feel like I don't know if I can live up to the expectations of what I'm going to talk about following Dr. Atala, because I don't even think I'm in the same league. But I did get a token of appreciation from the society. We have our custom designed pins, and I want to present you with one for you to take away and remember us.
Thank you so much.
A pleasure. Professor Aaron, I have one for you as well, if you like. To remember the Focal Society, I'll bring that over to you. I want to get you up, and then I'll get my talk started. Thank you very much for listening. I've never presented to an adult lawyer. No, I'm not going to. Interventional talk number 1, Rastinehad.
Where's mine?
I got one left. I brought 3. You got to be a believer now. It's always a tough space to be in. I always joke, my specialty, I'm a urologic oncologist. I'm going to talk about the field and where it goes. I'm waiting for my slides to come up. But I was a kid and I loved space, and I wanted to go to space. And you know, interventional radiology is one of the few specialties that you can actually perform in zero gravity, because we do everything percutaneously, because you can't operate surgically because blood just floats out of the patient. You need gravity to heal. And therefore, interventional, we can treat tumors, we can do drainages, we can treat a lot of benign disease and emergencies in space. So I don't know if I'm going to get there, but hopefully I can take you on the adventure of changing urology and hopefully the future of our specialty. It's talk 1-Rastinehad, the future of interventional urology. The focal, while I have a moment for my slides, please get involved. Okay, that's it. Here we go. Welcome. I'm going to tell you a little bit about myself and the story and how the field is changing. These are my disclosures. What's our mission? You know, we want to improve men's health care, but how are we going to get there? And I believe the future is through collaboration, developing hybrid training and research programs, evaluating new technologies, and implementing that to our armamentarium for patient care. What's the problem with medicine today? And I think those are the challenges. We've all existed in our silos. We have urology over here, radiology, and interventional radiology. I like to propose the theory that all of these are the same, and how do we put this together to improve patient care? Medical knowledge and technology has progressed rapidly, especially over the last decade. We've had new ways to diagnose, treat. A lot of centers use multidisciplinary teams to use these new technologies, but it's still the same old model. You have to sit down in a group and go through this with each other and bounce ideas off. What if we just put that all into one person? We train them understanding all of these new technologies, the biology of disease, and that's one of the unique things in urology. I think we do men's health, but we have all aspects of it. And the biology of disease is important in decision-making and what treatments we pick. And I've codified this to call this interventional urology. A little bit about myself. Everyone always asks. I don't want to spend a lot of time on myself because then I look like I'm a little pompous, but you know. But the important thing is I'm an accidental tourist in medical education. I was a medical student. No one wanted to do a project. They sent me to be a medical assistant or a researcher in the interventional radiology department from the urology department. I developed a friendship. I became a urology resident, completed an interventional urology fellowship, went to the NIH. I did 2 fellowships there. One is SUO to understand the biology of disease we discussed, as well as interventional or image-guided oncology. Why is this important? Because I think all the Venn diagram really brings it together. It shows us that these are important aspects we can put together to optimize R&D. And I spent a lot of my career researching new technologies. We have a book. We've had a couple books in the field. We had the seminal textbook come out almost a decade ago now today. It covers multiple aspects of urology in respect to embolization, intravascular interventions, percutaneous interventions, and drainages, and all that's in between. What am I going to cover today? I'm trying to tell you the story of how we get together. I was talking to Marianne the other day, and she talked about syphilis, and I was like, oh, I have actually that little slide right there. I've been pushing that boulder up the hill, and it keeps crashing down on me on the next project we start. But we're going to cover imaging, biopsy, focal therapy, prostate embolization, and varicocele embolization. And can you do this? Is there a pathway forward? We cover malignant and benign conditions and advanced imaging techniques. Urologists are boarded in the United States. We have imaging in our boards, allows us to be able to have interventions in that space. I've just pushed the envelope a little more than we did in the past. A quick story. I thought I was special, but then when you have a dad that's a urologist, you're never special. And he graduated in 1972, and I told him I was going to do intravascular work. He's like, that's nothing. We were doing direct aortic punctures, doing renal angiograms, looking for tumors in the early 70s. You just have better technology, but that's what we were doing back then. And Dr. Clayman wrote a paper on medical science, the future, talking about renal angiograms, looking for masses before we had CTs. And how can we integrate this into your practice? Again, I love the slide, current urology practice, state of the art. We're not there today in all aspects, and our training is limited. Urologists do not feel comfortable in interpreting films, specifically MRI, usually planning for surgeries, and I talked about that yesterday in my talk about the impact of imaging on surgical decision making. We talked about the evolution of the biopsy, digital to digital, and a lot has changed in the last, unfortunately, I can't believe it's almost 20 years of changing how we do biopsies. The big breakthroughs in the 70s and 80s was ultrasound, you could see the prostate, it wasn't digital. We had the biopsy needle guide in the gun, PSA in 1994. The field continues to evolve, and we should not get out of the way, but we should get on that train and continue to do this. Gio and I were talking about focal therapy and AI. Hamilton and I were talking about it as well. The problem is that our experience and our understanding of the field colors our conclusion or impacts it. If you have poor MRI, prostate is multifocal, you can't possibly do focal therapy because we're missing tumors. I don't believe that's so. Put more time into the MRI. I have spent almost 30–40% of my career in the imaging section improving this to try to educate all of us. So don't be the prisoner. I've showed you examples of high quality MRI. We've changed the paradigm in risk stratification of prostate cancer. Who should have a biopsy? Why? No longer do you do a PSA and a DRE and go straight to biopsy. We banned it at our institution. If the patient can qualify for an MRI and there's no contraindications, they get an MRI before biopsy. If there's a visible lesion, it must be targeted. If it's a negative MRI and there's a high suspicion, you have to perform a fusion biopsy and track those cores so then we can do QA to check if stuff's missing. And we have a 3D data set that right now is over 7,000 MRIs with 3D imaging, video of the procedure, everything is tracked. So we can build these models to test AI, what's the radiomics, what are the features, and how well the urologist is performing the biopsy. And we started the program, I left and came back to Northwell, I built the program the first time, went to Sinai, came back. Kawusi just gave me carte blanche. What do you want to do? And we mandated specific things. And one thing we mandated, if you want to do a fusion biopsy, you had to come once or twice a month to a 1-hour session, how to read an MRI and segment and target. Our cancer detection went up 10%. When you do 3,000 fusion biopsies a year, that's a significant impact on patient care. And I think these are really important aspects of what we do is understanding the imaging. You can see my underlying theme of my talk is learn to read an MRI and learn how to use imaging to improve patient care. I showed you the slide yesterday, but the 3 major companies, you can see when they had their FDA clearance, and you see the growth of the field. And as of January 1st, we have new codes highlighting the use and pushing people to fusion biopsy with lowering the reimbursement on a standard ultrasound-guided only biopsy. It's finally here. It almost took us almost 18 years to get to this point, which is the challenge in medical science. Like Tony's talking about in his talk, it takes forever to get to market and impact patient care. But this is what's exciting. And, you know, Brad Wood did have to retract his statement that a biopsy without imaging is malpractice. He was just 11 years too early. Another area is looking at the impact of multiparametric MRI just on publications and screening through prostate cancer. The beginning of Fusion 2007, you can see the NICE guidelines, the PROMISE trial and Precision trials, both level 1 data supporting the use. I think there's not really an excuse for skipping an MRI if you want to risk stratify a patient and optimize your understanding of the disease. We talk about who needs lymph node dissections and what staging is needed. The multiparametric MRI, I think, is the cornerstone of all of these things. The funnel I talked about yesterday, I'll keep it short, but as we have new biomarkers, new abilities to image and select patients, PSMA may play a role in the future in this. The problem is a screening test. I think it's a little bit overkill, but prior to treatment, it's an option to better stratify who should be treated. Because at the end of the day, we want to provide oncologic treatments to patients that have a cancer-specific improvement in their outcome. Besides, the morbidity associated with these diseases, the treatment sometimes is worse. The one slide, I always put this up. I had a longer version of it yesterday, but I really want everyone in the audience to see this is the single best MRI I've ever created. It was done on a 3 Tesla with a coil technology for an R&D project. But you can see all aspects. You can see nerves. You can see the capsule. You can see blood vessels. You see the surgical capsule, and you can see how the tumor slowly infiltrates the peripheral zone. I still see this patient. This MRI is actually almost 10 years old. But your conclusions, when I talk about being a prisoner of the cave, this is the NIH 2012 paper saying that tumor volume is only underestimated about 7%. This was from UCLA, Margolis's group, 80%. And this was NYU, 14%. So you can see the quality of your MRI will have a significant impact on what you believe you can do in the prostate cancer space. So if you're using information like this, your focal therapy outcomes will be horrible. Horrible. And then on top of that, if you base an AI algorithm and sell a commercial product, this will not have a huge impact on what your decision making is. And also, they treat the entire core as positive. So there's this bleed in the direction that you acquire the core in. I'm not telling you what company it is because I'm being nice, but Gio's over there nodding his head. So these are the challenges. And then they come out and tell urologists, I have this AI platform for you. I think it's buyer beware until you understand the data. And the data presented with respect to the AI, what's the threshold for clinically significant? How well does the model perform? On a 1 centimeter lesion, that was the group project regarding when can we predict prostate cancer and how well does it do. Those are enormous lesions. We need to move that threshold down to the 0.2 cc, where STAMI was originally talking about what was a clinically insignificant tumor. I understand at that point he was just using Gleason score, and we know a lot more about the somatic mutations in these cells that predict metastases, but we have to really, I think, move the needle a lot more. Positive surgical margin. Now that's the dirty word. That is the thing that makes your heart stop when you look at your path report after you do a prostatectomy. It's the thing that you don't want. Looking at the SEER data, 1 in 4 men leave the hospital with prostate cancer after surgery. That should shock you. And we don't do as well as breast, but we're 4 times higher than the breast market. Yes, the breast is a little bit easier to operate on, but still, as oncologists, our metric is 1 in 4 for the SEER data. Cancer centers are around 10% per se, but this is SEER data. So it's really, I think, something some people should understand, and this is like, people want to talk about, it's not really clinically significant, it's just maybe an artifact of pathologists, my pathologist overcalls it. Everyone has an excuse. But the big data does show that this does impact biochemical occurrence rates and progression to metastatic disease. We did a study working with Ash Tiwari, just taking the 3D imaging. You figure Ash is a phenomenal surgeon. He's one of the best I've seen. The ability to take what you see on a multiparametric MRI and put that together with the intraoperative surgical space is a disconnect. Ash reads MRIs. Ash had a 50% decrease in his own cohort in positive margins, and he's one of the people that gets so close to the prostate, does an incredible nerve-sparing prostatectomy. But even for him to have a 49% reduction, it's just a memory cue when you're operating. Where exactly am I in the space? This is not complicated. It's literally, this was our basic 3D model. We've upgraded the model since then. But I think it's something to say, like, hey, if one of the best robotic surgeons in the world can have an impact with having live imaging, understanding where every core was positive and where those lesions are, I think that's an important aspect, and it has an impact in our care. What does it cost us? Oh, about $1 billion on a 10-year life cycle of a patient by the time they progress through to metastatic disease. because the cost of these advanced treatments is significant. Because if you have a positive margin, just to go through the numbers, 25% have a positive margin, 50% will have an increase in their BCR. This is all comers from the SEER database, and then 25% will progress to metastatic disease. Then the question is, if you can see it, doc, and you biopsy it, why can't you just treat it? Focal therapy is still investigational, but this is what was talking about Hamlet. Hear me now, believe me later. This is what Luke Cavusi would say sometimes when he was lecturing me. Hear me now, believe me later. This is the future. I think focal therapy will be a part of the armamentarium, without a doubt. Why? Because in kidney cancer, we have parity and PT1A disease, ablation and partial nephrectomy. What are our limitations? Understanding the volume and the degree of tumor to conquer the hill of multifocality. And I think we are doing a good job of getting there, and combinations with PET imaging and MRI may be our future. And every institution has different results, and you see that through your own lens. But in the society, we built a multinational registry looking at this to collect data to hopefully better answer this in multiple different markets and different people's experiences. The evolution of prostate cancer, we've come so far. Since 1853, J. Adams described prostate cancer. We all know the giants in the field, Hugh Hampton Young with his perineal prostatectomy description. One of the only two urologists to win a Nobel Prize for medicine, Charles Huggins, looking at ADT and castration in prostate cancer cells. Does anyone know who the other urologist is that won a Nobel Prize in urology for medicine?
With Charles Huggins.
No, not with him, but
Another one? I don't remember.
there's another one. He convinced a nurse to put a ureteral catheter into his basilic vein, brachial vein, and catheterize the heart. It's Fernstrom. He got fired from cardiology, and then he became a urologist as a fallback plan. He went to the hospital a few floors down to the x-ray machine, took an x-ray, and showed that you could catheterize the heart from a peripheral vein. That was the first cardiac catheterization. So there's one of two. It was in the AUA Residence Bowl a few years ago, so I was like, oh, that's great. Someone's remembering that.
Is that right, Aaron? Yeah?
I probably didn't say his name right because it's German, but first cardiac catheterization. So you know what? Urology is a great fallback plan. If you're interested, we have room for anybody. So in the 80s, we talked about the evolution of PSA, truss biopsy, Pat Walsh, giant, describing the nerve-sparing prostatectomy. But then really 2009 was the NIH group, which I was lucky to be a part of by just randomly, again, accidental tourist in medicine. I got to work in Peter Pinto's lab with Brad Wood, Pete Choike, and really laid the foundation for imaging and fusion biopsy. The first time we presented at the AUA, there was two abstracts. Me with Hash Ahmed from the Embertons group. The two of us were the only two, and people were making fun of us. You think you can see inside the prostate? That's never going to happen. A year later, people are like, what sequences are you using? So it really changed a lot. But what's next, I really think, is the future is focal therapy. It's going to be a part of it. There's no reason to take out the entire gland if there's just one part that has disease. Emberton, Mark's group from UCL spent a lot of time. They did a study. They looked at a retrospective analysis, how many patients would have actually been focal therapy candidates using radical prostatectomies. 51% could have avoided surgery. I think that's significant. I don't think we'll ever get to that point, but if you think about what those numbers are, that's, I think, profound. We did some work in nanoshell, using nanoshells. We're the first group to use inhuman nanoparticles to ablate cancer. We had a successful trial. Unfortunately, I don't think this is ever going to make it to commercial market due to the FDA requirements. They need us to sterilize this with a certain degree of radiation, and the amount of radiation we need to use destroys the nanoparticles. So we have some development issues to still overcome, but it was really exciting. And I got to work with some Naomi Hallis, which is the woman that invented these nanoshells that preferentially get taken up by tumors. So what's really cool? What's the basics? What is every urologist going to have in their office? Fusion biopsy technology. And this is what it looks like today. This is the standard integration of what you see, ultrasound on the top and a hybrid screen, your MRI, and then your targeting area. If you're able to put all this together, now we can go to each part of the prostate and sample it. So step one, we can biopsy it. The next is we can create these 3D models using the platform for surgical planning, understanding what's happening in the pelvis in 3D space. This is the new model for guiding prostatectomies as well. We pump this into the robot. You can pull out different features and change to better visualize where that tumor is. What's the newest kid on the block? This is the most exciting thing we have today is water vapor ablation. They have obtained FDA clearance for their technology. What is it? It's the same thing as we use for BPH, just a deeper needle that you're able to access portion of the prostate and you apply steam. It's very easy. There's a lot of energy stored in steam with the phase change, and that energy that can be deposited in the prostate tissue to cause ablation. And how's it working? What's their data look? Oh, here's just an example. You can, does it start? Yeah, there you go. So you're able to do this. There's an ultrasound in the rectum. The scope is through the penis, so there's no incisions. They tried transperineally, but the steam kept leaking along the needle originally. But you're able to put the steam in to ablate this area, and it stays within the capsular margin. So it's in the peripheral zone or within the transition zone, and you just treat laterally, then medially, and we go above, below, and around. It's less than an hour treatment. So this is, I think, what's the newest thing, and this is what's exciting us. What's also nice, Gray group shoe, negative biopsy. 90% had a negative biopsy on trial at 6 months. I think that's really where our metric is for true ablation. Other technologies that gained FDA clearance for ablation were in the 60s for their application. I'm not going to say who, but we understand that there's a large disparity in the results of significant ablation. But what's important? Hashamed, the European, spent a lot of time on what's treatment of regret. And the trial did assess this. So you're looking at strongly, I regret the choice that I made, disagree. So there's maybe a 28%, but if you, not 28%, sorry, only 10% really are unhappy with the treatment at the most that fall here. So they're pleased with their choice. They had a good oncologic outcome. The long-term data is still out, but we have parity at 8 years with prostatectomy. What I'm trying to do is take you on this story of how we're incorporating all these new technologies with oncologic metrics to hopefully change the way we provide care for patients. Switching gears, BPH. It's probably one of the largest markets in urology. 90% of men have some symptoms of BPH after the age of 45. It's a social disease. It impacts your structure, how you see the world. Are you always searching for a bathroom? What's the problem? Almost everything we do causes some type of ejaculatory or erectile dysfunction in this space. And we're trying to improve that. My space is prostate artery embolization. It was FDA cleared for embolization in 2016. The AUA only endorsed it last year as a possible treatment. I think there's a significant amount of bias associated with that in that group because there's only 2 urologists at the time that actually did the procedure, besides the interventional radiologist. But just to go over that history, I told you I was a medical student in 2001. This was a first paper, a PAE series, published in urology by urologists and interventionalists working together. It wasn't until 2010 where the Europeans and the Brazilians really took off with it to research and develop the data to support this. What's that look?
You mentioned Brazilian, that's right.
I like to support Brazil. Obrigado. And then as we look through the transitions, it's only grown. But you know, in 2023, I was one of the first people to use liquid embolics for prostate embolization. We're changing that. It's great for pre-op surgical or large simples because the glue obstructs the entire vascular system, so it doesn't bleed at all. There's a lot of potential for concomitant surgeries to help support us, as well as a primary modality for treatment. The technology. There's 3D mapping, vessel mapping. The Monarch device people are using in the ureters. Some people are developing the robot for intravascular work today. I don't know if that's viable for prostate because the prostate artery is only about 2 millimeters in some cases, so you need a very low profile system to get through. But there's a lot of great technology. So people that are novices that don't understand the 3D anatomy, there's technology where you just do a run, a digital subtracted angiography, and it can map the vessel where to go and how to follow it. We just recently published this paper. This is an example of a liquid embolic. You can see every vessel's filled with the glue to obstruct it, and then we grade it 1, 2, and 3. Why do we come up with a grading system? The Europeans and I had 2 different ways to approach this. I published my paper 2 years ago. I had to wait 2 years for them to let me get my paper to press because they said they said it first. And as a urologist, I had a really tough hill to climb to get this in the JVIR. But this is reproducible, intra-reader reproducibility, intra-reader reproducibility, because when the patient comes to clinic, I'm like, how are they doing? Why do they have symptoms? Did we do a good job? Don't forget, we have fellows working with me. So not everything's going to be a perfect grade 3 embolization. So what are we going to do? It gives us a better understanding of what the outcome is. And in PAE, there's no other way to know because particles are not visualized, which is the standard thing that is done. Does PAE work? Placebo-controlled trial with a sham with a crossover. It works. Does it have the same durability as cutting tissue? Probably not. But after a PAE in our series, our patients had better erections, little to no retrograde ejaculation, and 90% did not need a catheter to have the procedure done. If you're looking for a first step that has the least risk, this is, I think, one of the best options. Why is it not endorsed by urology? Because not a lot of urologists do it. Tim McClure, myself, and 3 of my fellows. That's all we got so far. I'm trying. It's a slow process to help expand it in the urology workforce, but I think that's part of the future. Varicocele embolization. This is, I think, our sweet spot to teach people. Ahmed Ghazi and myself, we're going to work on developing a training model for residents to teach them this procedure. Why? Venous access, lower risk. Less complications there. A left-sided grade 3 can be done in 15 to 20 minutes in your office that is pain-free. So let me show you. Basically, this is easy. You make a femoral, you can do femoral or jugular access, come in, and you're able to get a catheter down to visualize the gonadal vein. I don't always do the venogram. This is an older study just for teaching. You can see the pampiniform plexus. You can see how one vein comes down and then it breaks apart. We never put coils below the internal inguinal ring because a patient may feel it. But otherwise, it's easy to access. What's the upside? No hydroceles, no testicular ischemia. Really, it doesn't have any of the complications our surgery does. And in 5 days, the patient can go back to full activity with no restrictions. And that's just made up. We just say 5 days because that's what we've always said. No one's really studied the duration, but that's just because we make a vascular hole. We say 5 days wait for arterial or veins. We place coils. I use coils, liquid embolic sclerosants, to improve the outcome. And what's the outcome? If your urologist writes it without interventional support, they say it's 90%. If you write as interventional, it's 93 to 95%. It does not meet the same metrics as a microsurgical, which is 98% success rate, but I think it's a great first step as well if you're talking a 3 to 5% difference. It's fun, quick, easy to learn, and I can teach anyone to do this in 10 cases. It's all about the other safety checks, understanding the standard practices of interventional radiology, but overall, in 10 cases, I could have someone learning this. So after my talk, do you think this is an area urologists should pursue? And how do we keep moving it forward? Residents, training, they should be a push to include imaging similar to many general surgery programs. We put our kids in radiology, we put our kids in IR so they learn this. But I think this is a missed opportunity if you're not doing this. And Lou Cavusi, early on, every resident LIJ had to do 3 months of IR. I think it's just to understand it, and I think it was a great way to develop collaborations between the departments. The evolution of the training paradigm, I've alluded to this during my talk. Specialized fellowships, it can be incorporated in endourology, urologic oncology. There are specialized training needed, but I think this is an opportunity, and I started my first fellowship in 2021. Privileges, it's all based on credentialing. How many have you done? How efficient are you with this? And what's your complication rates? And it's just, if you're safe doing it, I don't think it's that difficult. My fellows have got credentialed in the past, and I've been credentialed at 3 different hospital systems. Tom Sauce, he's just an innovator from Cornell. He's always talked about it. He's like, interventional radiology can't control everything because the one thing the urologists control are patients or vascular surgeons. They don't have the understanding yet, but they understand the disease and they have the patients. The only thing left is the skill in the stool to make it stand up and work. And are we willing to put that time in for that? And don't be last, because vascular surgery, neurology, cardiology, pain management have all adopted these strategies. And I think this is something that we should be doing, and all your residents should have some exposure to this. Last two slides. I hate doing this. I hate putting the finances up to try to justify what I do. But when you put the finances in, interventional urology programs have spread like wildfire across the United States. There's two companies competing to be able to have the most centers open, and urology practices are hiring an interventional to do this because it's so lucrative. I didn't go into this because it was lucrative, but I'm trying to sell my idea to balance the side of the coin, because you can't do great stuff if it's not paid for. So there's a lot of growth and a lot of financial potential. What do we have in New York? I have a functioning hybrid practice, multiple trials, interventional radiology fellowships, education, and there's a lot of opportunity. And if you're interested, please feel free to reach out to me. And I think there's amazing things happening through a pinhole. Thank you.
Hey, thank you. Great talk, Art. Thank you. And actually, I have one question. I understand that, as I mentioned before, I'm not a huge fan of focal therapy, but actually for prostate cancer. But you're convincing me that the most important thing concerning focal therapy is imaging. Is that right? Do you think that this upcoming radiomics and radiogenomics will help us at which point? What level is the importance of radiomics and radiogenomics in focal therapy, especially for prostate cancer?
So as Gio was talking about, and I've mentioned, the challenge is the acquisition of the quality of imaging. The second is interpretation. And then there's interpretation over time, like does it change after you've treated? And I'm working with Anat Abushi's lab at Emory. We have a joint collaboration. We're looking at, can we predict when patients are going to fail focal therapy before treatment due to radiomic features? We're looking to, can we determine what the best margin for treatment? Because I showed you that the imaging matters for how big of a margin you make, and margin equals time. And we were discussing, do you just do hemiablation if you can't localize the tumor? So we're trying to shrink the amount of time by increasing the information. And one thing lastly is that the swing between PSMA and MRI is only about 9% miss on either side. So if you combine them together, you get a better performance. So I think there's maybe some area to be explored there. However, the false positives with respect to PSMA, I don't want that to exclude a patient from focal therapy. Because at the end of the day, if it's not visualized the tumor on high quality MRI, the probability of that being clinically significant is much lower.
Thank you, Ward. Do you have a question, Ahmed? One question, because Raphael is almost with us. Come on.